Hello, and welcome to today's webinar titled More Than Meets the Eye, Understanding Ocular Tuberculosis. My name is Ann Scarpetta, and I will be moderating this session as well as providing some information on case management aspects specific to tuberculosis in the eye. I am a tuberculosis nurse consultant with almost 20 years of experience in public health and tuberculosis, but I have also worked in diverse healthcare settings such as acute and long-term care, hospice, and correctional health care. Thank you for joining today. We have no disclosures as presenters. Here is our agenda for today's webinar. And by the end of the session, participants will be able to know how tuberculosis in the eye, or ocular TB, is identified through integrated immunological, radiological, and clinical assessments. They're going to learn how to implement and monitor evidence-based treatment while managing vision-related risks and strengthen patient and community outcomes through effective interpersonal collaboration and preventative strategies. And now I would like to turn this over to Dr. Kevin Winthrop. Dr. Kevin Winthrop is a professor of public health at Oregon Health and Science University and Portland State University School of Public Health, and he is also a professor of infectious diseases and ophthalmology at Oregon Health and Science University School of Medicine. A former infectious disease epidemiologist in the CDC's Division of Tuberculosis Elimination, Dr. Winthrop has authored more than 400 publications on tuberculosis, opportunistic infections, and infections associated with biological immunosuppressive therapies. He directs a national referral center for chronic chest infections at OHSU, serves as medical consultant to the state of Oregon's Tuberculosis Control Program, and is actively involved in clinical research, interprofessional collaboration, and mentoring the next generation of public health and medical professionals.
Good. Thanks, Ann. Thanks to Ann, Jeannie, and Lisa for organizing this. This is kind of a fun topic to talk about. It's fairly rare, but it's increasingly incident, as you know, and that's, I think, why we're all talking about it today. As Ann said, I'm a professor at Oregon Health Science University, and I run our mycobacterial program. I'm also the state TB consultant to state of Oregon, and worked at the CDC TB division years ago as a medical officer. And I've been out here about 20 years now, or 18 years, something like that. So happy to talk about ocular TB. So I run a mycobacterial infectious disease center, but I also consult in ophthalmology and see these cases, and they are tough to diagnose and tough to treat. So I'd like to just show you some pictures, give you an overview of the epi and some manifestations of disease, and make some comments on diagnosis and treatment. And then turn it back to Ann, like she said, to kind of go through the nitty-gritty of how to manage the cases. This patient is a patient with classic TB episcleritis. There's a few forms of TB that are somewhat classic in the eye. This is one, and you can see the sclera is the white part of the eye. There's a lining outside the sclera. In this case, it's very inflamed here. You can see nasally all that redness, and you can also see out here temporally. And in the other pictures, you can see this kind of raised, bubbly, kind of down here, raised and bubbly. These are just inflammatory. It's just inflammation. And there's probably some granulomatous implants or little nodules in the episclera. This can progress and eventually involve the sclera, the white tissue underneath, and eventually, erode into the eye ball itself if it's left unchecked. There you go. You can see these little granulomatous lesions here. And again, this raised red erythematous area. So this is a cornea to the left. It's uninvolved right now. It's unusual to be involved, but this is outside the eyeball. So it's extraocular really, but it involves the eye. And I'll show you some other forms of TB in a second. So we did do a little project a couple of years ago at the state of Oregon to try to better understand the epi. And we looked at all of our data in Oregon. We also contacted some surrounding states, including Colorado. and asked about ocular TB case reports. We also looked at the eye and ear appendage case reports. So, when you report your TB to CDC, it gets bucketed into pulmonary or extrapulmonary. And if it's extrapulmonary, there's different boxes to check. And one is eye and ear. So those are combined. And of course, I have seen ear TB, but I don't think ear TB is really going up in incidence. It's pretty darn rare, but we suffice to say, we don't have a distinct ocular bucket with CDC national reporting data. We have it combined with ear. And then I would just say here in Oregon, all of our eye ear appendage cases are not surprisingly eye cases. We just don't see very much ear TB. National trends, I'll just tell you that ocular cases have been increasing since 1993 slowly. Much more rapid increase after 2008 and 9, once really iGRIS became more available used in clinic. And I'll show you some of that data that substantiates that in a sec. And we really see this increase across all age groups. Very few of these cases are lab confirmed, which is probably a source of discontent and worry among most providing care for these cases. And I don't have a diagnostic slide here, but I'll just tell you that sampling the eye, as probably is pretty low yield. If it's the front part of the eye, you can get a tap done with the needle and pull out a little aqueous humor, which is the fluid in the front part of the eye. That's relatively safe and easy to do, but it's a really low volume of fluid, and it tends to be poorly sensitive even when you send it off for PCR. The back part of that vitrectomies, if the patient needs a vitrectomy, like they have a retinal problem or they actually have to get the gel or fluid out of the back of the eye, if you send all of it or a big chunk of it, that can be a fairly sensitive diagnostic maneuver for culture and for PCR. But it's pretty rare that you want to go do a vitrectomy, because vitrectomies have a lot of risks. And I would say 1 out of about 15 or 20 of these cases, you end up getting the opportunity to get vitreous to be cultured, but typically you don't. So usually you have a peripheral, you have evidence of prior exposure, you have a positive iGRIS or a skin test, and that's what kind of raises the suspicion. So I will tell you this too, and I have this slide in a different slide set, but there are new ways to diagnose this. I mean, we're moving towards like cell-free DNA techniques that can be done in the blood or off ocular tissues. And, eventually we're going to have more sensitive ways to diagnose this, but they're probably 5 years out. So here's the epi, back to the epi. This is just a graph of the last 20 years, basically. And you can see the national eye ear reported cases have been going up. In Oregon, we see this kind of little tiny blip up after 2009. Of course, we have very few cases in Oregon compared to the country, so the line looks small, but you can see it's up, and you can see this rise nationally. And again, most of these eye ear cases are eye cases. I don't think any are ear cases. You can see the percent of other, basically the eye and ear cases are labeled as other, and you can see the percent has been increasing of the total TB cases nationally over that time period. So that's 2010 to 2020. It's gone from 17 to 26%. So this includes eye, ear, and other places. But again, it just suffices to say a lot of this is being driven by ocular cases. And when you look at Oregon specifically, you can see that the percent of TB cases that are ocular ranges between about 2 or 3 and 8, depending on the year. And the U.S. average here is below. And again, it's gone up since the advent of iGRIS usage. So it's about 1% now total. So 1% of TB cases in the U.S. roughly are ocular. Another way to look at this, I think I told you we kind of explored this with some other states, Utah, Michigan, and Arizona. And I thought Colorado was involved in this too, but maybe not. So I misspoke. But the blue bars represent the percent of total TB that was basically ocular prior to 2008. And then after 2008 is the red bar or the orange bar. I'm colorblind, sorry. But you can see in each of these states, before a lot of IGRA usage. There was very little ocular TB. Now there's lots of ocular TB. So it does raise the question, are we just overcalling ocular TB, or are we finally catching people who have it, and we didn't catch them before? And the answer to that question is probably both, right? We have a more sensitive way of looking at this now, but IGRAs aren't specific, of course, for active TB or even ocular TB. So I'm sure some of these cases aren't true cases, which is what makes it so hard to diagnose this entity, the fact that you can't sample the eye easily. But on the other hand, I think some of these cases that are presenting, like the case I just showed you, they've got episcleritis. They may not have been labeled as TB in 2007, but now that there's an easy way to get blood, do an IGRA, and the ophthalmologist may say, oh, maybe this is TB. So I do think that has enhanced diagnosis. A couple other epi slides. Percent of all TB cases are ocular. I just kind of showed you the Oregon data, but this was a 5-year average. There's something special about Utah and something special about Oregon and Illinois. I think what's special about these places actually is that they have really well-known, internationally well-known uveitis centers. A lot of people get referred to these places with difficult to treat uveitis, which is the word for inflammation of the eye. So I think probably this is a diagnostic bias in those places, that these centers are just collecting cases from surrounding states. That would be my guess as to why it's higher in those places. So when we looked at our cases in Oregon, I was just curious about a couple of things. What did they look like? Were they unilateral, or did they involve both eyes? What were the presentations and what were the outcomes? So we reviewed like 28 cases that had occurred over 9 years, and average age was 51. Most were male. Foreign born was 60%. Usually in Oregon, it's more like 70-75% for TB overall, and even higher depending on the year. And you can see race, ethnicity was evenly split between those categories. The risk factors, it's not really interesting other than they have all the same risk factors as normal TB cases or non-ocular TB cases. And again, a lot of these folks were foreign born, not surprisingly, but they all had essentially at least one risk factor for being exposed to TB previously. 28 out of 28, all were QFT positive. One of the cases, actually, there was a 29th case. It wasn't tested, so I don't have it in here, but 28 out of 28 were positive. Only one had lab verification. That was a patient that did have a vitrectomy, and that was PCR positive. So there was really 1 out of 28 actually had intraocular sampling that was positive. So in terms of presentation, well, they almost always get labeled as uveitis, but they may not if only one distinct tissue of the eye is inflamed. Chorioretinitis is very classic. That's the back part of the eye. The retina is the nerve in the back that spreads out, and then behind the retina is the choroid. It's a highly vascular surface. Extrapulmonary TB, disseminated TB comes to the eye through the blood, and it comes right to the choroid. So oftentimes you see these manifestations in the back of the eye, and that would be chorioretinitis or choroiditis, where you see granulomatous inflammation in those tissues. Vitritis just means there's inflammatory debris or cells in the vitreous, the gel in the eye. Macular edema is swelling of the macula. That's your central point of vision in the retina. Those were the most common presentations, but there can be other presentations. The other was episcleritis and scleritis cases. This is more often in both eyes at the same time, and I thought this was interesting. So these people had unilateral disease right and left, but about 50% of the time it was both eyes at the same time. How do we treat these people? We had information for about 21 of these people, which represented 33 eyes. They all got drugs for between 6 and 12 months, and I'm going to comment on treatment duration in a second. Long term, these people get problems, right? They get cataracts, they get epiretinal membranes, which are, basically new growths and membranes that cover the retina that disturb vision. They can get ocular hypertension. They can bleed in the eye. A lot of these are long-term sequelae of having that chronic inflammation in the eye. Some of these things can be managed, but you can have quite a bit of visual loss due to ocular TB. So it is important to treat it, even if you're unsure. I often say, hey, why don't you just start treating it? Because you're not going to lose anything by starting early. You only lose by starting late. Um, a couple other cases, then I'll talk more about treatment. But this was a case who had a totally normal eye, but you can see her nice little white circle optic nerve in the center is no longer a little circle. It's all spread out. And if you looked at this in the microscope, it's 3D or 3D, you can see there's an elevated lesion here. And this person had just a granuloma of the optic nerve. And she was from Italy. She had no risk factors really for TB other than she was from Italy, which I don't think that's a risk factor, but that was the only interesting thing about her background. But she had this visual problem, and no one could figure out what this was until she landed in our clinic. And you can see her. This is a visual field test. These little yellow areas here tell you that there's visual loss. Like she's not seeing things that pop up in that section of her vision. So this shows that optic nerve is not working, and it's basically blocking her ability to see lights in that vision. We treated her for 12 months with a TB regimen, and you can see now her optic nerve looks essentially normal. There's a little bit of pallor here, meaning the nerve's been damaged a bit, but it was flat and it was normal, and it looks a lot different than it did right there. So, a fairly unusual presentation of TB, but there was absolutely no other explanation for it. The only reason we guessed TB because she had a positive IGR, we treated her for TB, and this resolved. So, again, there was no sampling. We were kind of just, it was a best guess, but it worked out. Oh yeah, and her field normalized. So now she's got really no big missing areas in her visual field. So she was happy. So some points about ocular TB. This can affect any structure in the eye. There are some classic structures like the sclera or episclera or the choroid that I mentioned. These are different presentations here. These little white dots here you can see are those are choroidal tubercles, they're called. They're basically little granulomatous or necrotic granulomas in the choroid. So what you're looking at here is the optic nerve and the blood vessels that come in through the nerve that spread out and feed the retina, which is basically this whole red surface. That's a nerve fiber layer that's spread out. Behind it is that highly vascularized tissue, the choroid, and that's where these little lesions are. Here you see the front part of the eye. This is someone who has vitritis or really just rip-roaring anterior uveitis and posterior uveitis. You can see a bunch of pus back in the vitreous here, and you can see this layer of pus here in the front of the cornea. That's called the hypopyon. And these little tiny white dots are called chorotic precipitates. They're basically conglomerations of white blood cells or granulomatous inflammation that's basically being stuck on the inside of the cornea. And here you have some inflammation around the retina. Lastly, sometimes we use OCT. This is the ocular CT scan. A colleague of mine here actually invented this, and he's unbelievably wealthy now. And he's won every award in the world. But it's amazing technology. And you can see, like, you look in the eye and cross-section, this is the retina. This is the nerve fiber layer here. And this depression here is your fovea, your central vision. This is the optic nerve coming in here and spreading out, and you see this beautiful retina. Underneath, you should not see this. You can see these little white bumps here, these hills. It should be nice and flat like it is out here. These are little subretinal deposits of inflammatory debris, TB and infection, and basically granulomas all underneath. So sometimes we can see the suggestion of these lesions on the OCT. It can be complementary to the actual ocular exam. Another fun case, this is really not ocular TB, but she presented to our clinic with a watery eye. And, some people get this condition. It's called epiphora chronic watery eye. There was no reason for it. I had the oculoplastic surgeon explore her nasal lacrimal duct, the little duct that goes between your eye and your nose. So when you cry, right, some of the tears go into your nose, you get a runny nose. Well, it turned out in there she had this big bump, this big lesion in her in her upper nasal area, and it kind of went into her nasal lacrimal duct, and it was biopsied, and there it is. That's a picture of her nasal lacrimal duct, and you can see these little granulomatous bumps here. So I had him biopsy those, and of course they grew out TB. And then in the meantime, about 2 weeks later, she developed these large necrotic lymph nodes on the side of her neck. So her TB had reactivated in her nasal lacrimal duct, and it was draining lymphatically to these lymph nodes, and now they were becoming infected. So this was a fascinating case of TB reactivation in a nasal lacrimal duct. So this illustrates one principle that, as you know, TB, when you're first infected, it disseminates everywhere before your body shuts it down. And it shuts it down with a granulomatous response. And, people who have latent TB effectively probably have, TB hidden away in cells or in granulomas really anywhere in their body, including your nasal lacrimal duct and including potentially in ocular tissues. A couple more things about diagnosis and treatment. We did this survey a couple years ago of international uveitis experts, and we kind of asked them what caused them to order a TB test, like an IGRA. And basically, anyone with TB risk factors, the majority of people ordered IGRAs. People with uveitis, run-of-the-mill, first time, most people didn't, but if they had systemic symptoms or they had TB risk factors, the majority did. I was kind of happy to see that. In terms of presentations, were there things that triggered people to order IGRAs more than others? And it was kind of not really, except for if it was in the posterior part of the eye, about 70% of people ordered an IGRA versus if it was in the anterior part of the eye. And I think that's true. I mean, TB presentations tend to be more in the choroid and the retina, other than the episcleritis outside the eye that I mentioned. So I think that's something I always consider when I'm consulted on these cases. I mean, there are some classic presentations of TB, like the episcleritis or the choroidal tubercles. But really, I showed you a couple weird cases. It can really affect anything in the eye. So you always have to keep it in mind. In terms of duration of therapy, it was kind of all over the place, but I would say most people treated between 6 to 12 months. So there's no data, there's no right answer about how long you should treat these people. There's this idea that, inside the back part of the eye, the retina and the optic nerve is an extension of the CNS, the central nervous system. So I think a lot of us, including myself, I mean, we tend to treat cases of TB where it's involving those posterior tissues as like CNS TB, and we'll treat them for 12 months. If it's anterior, like in the front part of the eye, like it's iritis, anterior iritis, or it's just in the front part, I think a lot of people are tempted to treat for 6 to 9 months. I mean, that's what I do. If it's outside the eye, like the episcleritis, I mean, it's really extraocular. I mean, you should be able to treat that with 6 months. And obviously, if it's on the outside, it's a lot easier to get a biopsy. So those episcleritis cases or scleritis cases often will ask the ophthalmologist to get a biopsy of that tissue, and that's going to be more sensitive than the small amounts of fluid that you can get from the front part of the eye. So you often may have a specimen to work with in those cases. So unique challenges. It's often hard to convince the patient that TB is the cause of their inflammation, particularly if they don't know about TB or if they're US born. Inflammatory eye disease often worsens during treatment before it gets better. So my experience is a lot of these people, this is not just like you show up and you have inflammatory eye disease the first time as TB. That could be true, but oftentimes these people are being diagnosed after 6, 12 months or longer of recurrent inflammatory eye disease. Often it responds to some prednisone, but then it bounces back and gets worse, or it recurs after, after 6 months or a year. And it's often like the second, third, fourth go around before someone thinks about TB and tests them, and it's actually the TB that's doing it. I will say that oftentimes you do treat these people and it does get worse the first month or two. And that's because you're basically causing a bunch of inflammation while you're killing the bugs. So, whether you ought to use concomitant steroids or methotrexate, some people do that. We try not to, as long as there's no vital structures of the eye that are being threatened, because I'd like to judge the treatment response of the antimicrobials alone. But if you have to, you have to use it. And then the last bullet there is that even if you treat this, that sometimes people still have continued flares of uveitis even years later, and we don't really understand why that is. We do think that some of the TB proteins look like retinal proteins, and that there's probably some mimicry involved that primes the immune system, and the immune system just reacts to those proteins, even though there's no active TB left. So in conclusion, ocular TB increases is rising in incidence. It corresponds with Agra introductions. So I think some of this detection bias, but again, I think we're diagnosing more real cases. It can be visually devastating. So we tend to err on the side of being more aggressive about treating and not just waiting to see if they respond to anti-inflammatory. Like I said, by the time most of these people present, they've had several attempts at anti-inflammatory therapy and they're not responding to it. And then length of therapy is unclear. But I told you the way I do it. It's usually posterior part of the eye, it's 12 months, anterior 6 to 9, outside of the eye, 6 to 9. So, and usually you can get away with 6. And continued inflammation does not imply active disease necessarily. So I think that's my last slide, and I'm sure I'll get some questions at some point, but I'm going to turn it back over to Anne.
Thank you, Dr. Winthrop, for providing some clarity to the diagnostic process for ocular TB. Building on your points, I will now be presenting on nursing strategies for ocular TB detection and clinical monitoring considerations. When we talk about TB nurse case management, we are really describing someone who wears a crucial quilt of many hats, each one essential to guiding our patients to wellness. Much like the case management of society's definition to general case management, a TB case manager is fundamentally a patient advocate, an evaluator, a planner, communicator, and a coordinator of care. Our work is a collaborative process of assessment, planning, and evaluation. But in the world of TB, this manifests in deeply practical and public health-oriented ways. The TB nurse case manager ties all of these functions together, ensuring that every patient reaches their optimum level of wellness and functional capacity. By doing this, we ensure the entire community's benefit. Ocular TB case management is arguably even more complex than typical pulmonary TB due to a combination of diagnostic ambiguity, the critical and delicate nature of the affected organ, lack of standardized treatment protocols. For example, a consensus on the length of treatment can range from months to over a year or even longer. The use of adjunct therapy like steroids. This uncertainty requires highly individualized care plans and multidisciplinary coordination. The psychosocial impacts and potential blindness is significant risk, providing unique clinical and psychosocial considerations that we definitely need to address in order to ensure patient safety. It's a difficult and presumptive diagnosis. There's a lack of vision, a risk of vision loss, concurrent use of steroids, similar to iris paradoxing worsening, as Kevin had stated earlier in his presentation. So when we look at case management, I wanted to break this down for you to be able to point to the various aspects of our nursing case management tasks. And in ocular TB and public health, we focus on ensuring complete adherence-driven treatment for a complex and often presumed diagnosis, which adds complexity, coordinating care across many specialties such as ophthalmology, infectious disease, or their primary care, all of these combined, and any other potential specialists that may be involved. We have to manage side effects like vision issues from ethambutol, or liver issues from INH or pyrazinamide, providing patient-centered care and education and social support, and linking the services to overcome barriers like housing and insurance, all crucial for stopping transmission and preserving the vision. We know that when we get a referral, you get a call from a doctor, you're ready to go. Like, you are ready to take off and get going. You may feel like you have everything you need because you've done tuberculosis case management before, but not ocular TB. So pretty soon you might feel like you are spinning your wheels at times. And this is not a one and done thing. You may feel like you're back on track and you might start spinning again. Our goal is to get you some key points or key tools even to be able to get you back on that road. It's important to remember this is not a drag race. It's more like the Le Mans in France. It's an endurance race that is 24 hours long, many curves, but there are some straightaways. Occasional rain, which slicks up the roads, hard to maintain traction, but you do. You do because you follow the guidance. You follow the standards of care. Both require long-term commitment, strategy, teamwork, and resilience to achieve the ultimate goal, which is, of course, getting the patient successfully through treatment with the best possible outcome. We are here to help you have a smooth and safe trip with the goal of getting your patient across that finish line. So let's take a look at that first piece of that roadmap, if you will. Coordination and collaboration in medical care. You are the clinical liaison as a case manager. You are the bridge between the patient and the specialized medical professionals. You're ensuring medical instructions are provided to the patients in comprehensible ways, and vice versa, providing the necessary information to the clinical specialist to be able to help guide that treatment regimen. This is very complex, and it can often get more complex with the medications we are providing. So it's very important to include that multidisciplinary communication in your process internally. The PHN coordinates this information flow between the patient and the ophthalmologist. We ensure that both the clinician and the patient receive timely updates, especially if it's pertaining to any screening that we're doing, like the vision acuity tool that we'll be talking about a little later, or retinal examinations that the ophthalmologists are performing, or the clinical response of the eye lesions. These are all crucial for guiding the overall duration of therapy. If applicable, coordinating with infectious disease specialists. So perhaps the ophthalmologist would like you to refer to, or what they would like to refer to, an infectious disease specialist. You may need to help coordinate that appointment for them to ensure that there is a timely appointment and all providers have what they need in order to accurately determine next steps or recommendations for that patient. Requesting any rule-out testing that haven't been completed yet. So that's part of this process. You're communicating with the medical providers and getting all of the information that they have done so far, any testing they've done so far, and then determine which tests that we still need to do in order to rule out any other potential problems like pulmonary TB as well as ocular TB. The medicine procurement, sorry, hard to say, is absolutely part of this. So you are in jurisdictions, I should say, that provide TB medications, the PHM would coordinate the provision and distribution of TB medications, and also potentially asking for other prescriptions that may be necessary to manage side effects and adverse reactions. Organizing virtual huddles to ensure that everything is communicated in the most efficient way. So having a multidisciplinary team meeting will help make the process much more efficient, make sure that everybody hears the same information and everybody is on the same page. So these consultations are essential for reconciling any discrepancies that you see between the providers or between treatment protocols, such as the length of treatment, the use of adjunctive corticosteroids or management strategies in the field that they may ask you to do. This is all pertinent information that you want. And the medical documentation, you make sure, just like you would in a hospital or clinic setting, we're going to be documenting everything that we do, the conversations that we have, and the responses from the providers on what they want to do. I wanted to talk just for 2 seconds about the integrated health data management system and reporting. So we not only have the responsibility of trying to pull all of the medical records together to be able to capture everything we need for data that we need to provide to the CDC because there are reporting requirements, but more importantly, I would say, for the patient care, right? So we may need to look at EMRs, electronic medical record systems, for some of this information. We may need to look at laboratory information systems like LIS. The nurse will grab those reports, such as any cultures, molecular testing, susceptibility testing, perhaps even monitoring, clinical monitoring like liver or HIV monitoring, et cetera. Radiological evidence, you might have to go to medical records to get some information on their clinical testing that they've had done, including the imaging that they have done. You also want to make sure that you have legal compliance, so making sure that all of your reports are completed and filed appropriately. All the data that's required for the national and state systems, registry systems are collected and documented as well. The next roadmap is the comprehensive assessment and individualized care plan. So I just want to note that care plans are not something that we normally do in local public health departments, but it is part of the nursing process. And I would encourage all of us as nurse case management in tuberculosis specifically to have more individualized care plans that are created specific to patient needs and goals. So the patient's initial meeting with the patient will you're going to introduce yourself and you're building rapport and you're collecting data. You are discussing patient privacy rights, getting consent to disclose information to others if they want family present or to be part of the conversations. You're going to often be providing education to the family as well. And it is very important to do this in the patient's first language. So making sure that all consents are in their first language, making sure that the communication's in their first language so that they fully understand this complex diagnosis. It's very important in general to do this, and it's a mandate by a federal law to provide this, but also I would say for ocular TB, because of the nuance of not having testing that confirms TB, it's that much more confusing for a patient to be able to say, why am I getting this treatment? So to be able to fully understand if the patient is comprehending what you're saying, you should have someone that is able to communicate all aspects of the discussion to the patient and to you. It's very important also for clinical monitoring. You need to know what's going on with the patient so that you can pass that back on to the provider and adjust accordingly so that we have the best outcome. You're going to be collecting another history of the date of onset for this ocular issue, the history of seeking care and treatment. You want to get this verbally from the patient as well. You don't want to rely just on medical records to get this information, because oftentimes information will change once we're in the home and we get a chance to educate the patient. They understand more, they comprehend more. We're giving the time and dedication to make sure that we answer their questions. So you may get new or different information, and it's not uncommon to do so in the home. So that's why it's so very important to redo this process in the home. And then we're going to look for the TB systems for other areas in their body. Just because it's in the eye or ocular TB does not mean it's not pulmonary. In fact, ocular TB is one of the references that I was reviewing and preparing for this, noted that 60% of patients with evidence of extrapulmonary TB may not have diagnosed pulmonary TB. But what that means is 40% do. So I have heard statistics from 17%, and now I'm seeing the 40%. I think the important thing to note is that we need to rule out pulmonary if we are suspecting ocular TB, just like we would for any other extrapulmonary TB. Pulmonary needs to be ruled out. Why is that? Because that's likely where it's landed first, and it's not abnormal to find it. And we need to know, because we need to know if we need to do a contact investigation. So it's not a step to be missed. Yeah, reviewing and coordinating diagnostic workup for anything that has not been done, that you've evaluated all of the medical information. You've gathered everything you've collected from EMRs and the providers and the hospitals, and you've noted some missing pieces. So you're going to try to coordinate that. It's not telling the patient to go get it done, because then it's not likely going to get done, and the provider's not going to know exactly what the reason is. So it is really you acting as the liaison to coordinate all of this care to ensure that the patient has the best outcome possible. Obviously, after we incorporate our nursing interventions, we want to evaluate and adjust as necessary. So this is not, again, a one and done. This is just, as we were taught in nursing school and practice in clinical settings, we are reevaluating, because the goal is to help make sure the patient succeeds, right, with the least amount of problems. So establishing a trusting relationship, the next road sign, patient and family education and psychosocial support. Seems like it would not be a very important step in the process when you're doing tuberculosis case management, but I would say that this is a make or break, or could be a make or break for your TB case management. You need to have a trusting relationship with your patient, meaning they have to feel comfortable with you. They have to believe that you're in it for them. They want to have an empathetic person who is listening and ensuring confidentiality, because there is a lot of stigma out there. Building rapport is your role as a clinical liaison. You can do this through a variety of ways, right? So assessing their psychosocial needs and their emotional state when you get there, providing clear and understandable education in their own language, and answering questions and addressing concerns. Using compassion and empathy during this process is critical, because you may have people asking you the same question numerous times every day, or they may state something that you didn't say that you have been saying very clearly, that you thought was very clearly stated. So these are all normal human reactions to an overwhelming, confusing diagnosis, especially if it's not provided in a way that they understand and can comprehend. So what I'm asking is just to ensure that you provide that respect and patience and empathy when delivering your care, because it is such an overwhelming and hard-hitting diagnosis for them, not having clinical evidence to support that it is tuberculosis disease. So it's arguably tougher because of that aspect. It's so such a gray diagnosis that you're going to get those questions. So you need to help alleviate some concerns. And of course, seeking out medical advice too. If they want to talk to the provider again, perhaps they have more questions that you aren't able to answer, connecting them with those who can is going to be also building that trust. Identifying and addressing stigma and privacy concerns, same as the emotional state and addressing concerns, but it builds up more specific to the privacy concerns. It's not uncommon for persons to have backlash if they say something about tuberculosis disease, and I'm sure you've all had some experience with this in the field. It's something that we take very seriously and can cause a lot of chaos for our patients. So really addressing that, asking them if this is going to be an issue. Don't wait for them to tell you or a story of something happening to them because of the stigma before you address it. And then see how you can help in those ways. There are tools that you can use, including depression screening tools available through some of the resources I'll be sharing in just a little bit. So empowering and involvement, providing the patient with the education in their first language, providing ample time for them to ask more questions or ask for clarity, addressing any concerns that they have about stigma and privacy will empower the client to be more involved in the process, including providing you with pertinent information such as side effects or adverse reactions they may be feeling. So you want them to feel that you are open enough and that they feel they're able to tell you anything that they need to tell you. So you are providing that safe space for them. So it's quite overwhelming for most people. They will likely, again, recall new information or modify things. This is not about them being deceitful or anything like that. This is typically, I'll say, this is more human nature, just coping mechanisms. And we need to understand as nurses that we need to continue to ask these questions and need to continue to address any concerns that they may have. So we definitely want to empower them. Encouragement motivates by boosting confidence and self-belief, releasing dopamine, motivation chemical in the brain, changing negative thought patterns and showing someone they are seen, valued, giving them courage to overcome obstacles, fostering resilience and improving their focus on effort and growth rather than inherent ability, making challenges less daunting and progress more achievable. And I think that's something that we need to recognize as a nurse, that by providing them, empowering them, provides them with the self-confidence and the self-belief that they can get through this. And oftentimes this is something that they have a hard time with in general. And again, because this is ocular TB, it's not just a fear of tuberculosis, but it's a fear of losing their vision permanently or having some other impact related to their vision. So this is definitely something that I think, have to grow on. We have to expand in this area. And then linking the care and community resources to, again, empower them, provide them with the resources to be able to feel like they have some hope. They have a way to get food, a way to find the housing, any other care that they may receive or haven't been receiving, connecting them to the care and resources that are available. And then treatment oversight and adherence. So this is what we are normally here for, right? Like we are watching them take their treatment. We always want to practice with empathetic, calming, reassuring voice, acknowledging the medication list that's long and the side effects can be worrying to people, but encouraging that they tell us. We are a safe space. Our goal is to get them through treatment without issues, or if there are issues, address them promptly so that we can get them back on track. Even if they're small or seem embarrassing to them, encourage them to bring those reports forward of any symptoms. It's so important, and there have been bad outcomes because persons not bringing those forward. And again, it's not a matter of them not being forthcoming for a purpose. It's usually because they don't want to bother you, they don't want to worry you, they think they're taking too much time, or they don't see the relationship between the meds and the side effects. So encourage honesty, reassure them that it's a safe space, and it's important to note all side effects, even if they seem small, and stop. So we are stopping any medications if there are any issues. In the clinical monitoring process, and I'm not saying, I should back up, we're stopping and calling. So stop and call. We are calling the provider who prescribed those medications and providing the details regarding the symptoms that they're having. So vision issues, any stomach issues that could be related to liver toxicity, and so on. So in these tools, when we work in the field, we have tools that are available. The Snellen and the Ishara are two of the tools that we use when persons are in ethambutol, which is one of the first 4-line drugs. The Snellen is the visual acuity test. The Ishara is the color blindness test, if you will. And we are monitoring baseline. So we start with that, and then we monitor monthly or more often while they're on ethambutol. If they report side effects, we'll do it more often. And of course, if they report side effects, you're stopping those meds, and you're contacting the provider to discuss before you give the next dose. They will either provide recommendations for further testing, or they'll tell you to hold the medications, restart them, et cetera. So definitely very, very important to stop and call the provider. Symptom review and checklist, we do that every day. If they have it, we would stop the med and call the doctor. Depression assessment tool, again, very important because a lot of our clientele do have a lot of psychosocial issues that they're already dealing with on top of this diagnosis that is so complex and questionable. So assessing that and providing the resources they need in the community if there is a need to do a referral. And certainly talk to the prescribing provider about your results of the tool. And lab work is going to be based on the provider and potential side effects that occur. So if a person has side effects, typically we stop the meds and we do some lab work and a clinical assessment to see if this is something that is significant enough to keep those meds off. And again, you are the clinical liaison, so you are responsible for making sure that all parties have that information that they need, that you do thorough evaluations. If a person reports a side effect, you get a thorough evaluation of that, right? Like if a person would report stomach pain, nausea, vomiting, I'd want to know how long did you have it? How long after you took the meds? Did you vomit? How long after you took the dose did you vomit? Did you vomit all of the meds? You want all of this. What's the pain like in the stomach? Rate it 1 to 10. Does it go away on its own? Do you take anything for it and it helps? These are all the things that we do in a hospital, normal setting, right? We don't do too much in the field, but this is what we need to do. We need to do the clinical monitoring that we have a license to do. We have a multiple choice question that we provided, and public health nurse is managing a case of a patient diagnosed with ocular TB. Which one of the following is the most critical component of public health nurses' case management strategies for this patient? Ensure the patient receives surgical correction, provide patient-centered care to ensure treatment completion through medication administration and clinical monitoring, focus only on the medication adherence without considering social factors, or refer to the ophthalmologist and close a record. It's B. We are providing patient-centered care to ensure treatment completion through medication administration and clinical monitoring. So the public health nurse ensures patient-centered care and guarantees treatment completion through two primary integrated functions, through direct observed therapy and clinical monitoring for adverse side effects. This is how the public health nurse works in her role in ocular TB case management. So when we do directly observed therapy, we are administering the medications and making sure that they ingest every dose. That's directly observed therapy. Done by a medically trained provider. It's a delegated task usually from the nurse, and the nurse case manager would ensure that this person does provide DOT, so they would be responsible for monitoring the DOT records and ensuring everything is done. The key point for that would be if you do have a delegated task to do the DOT, making sure that that person does understand that they should hold those medications and contact the provider, or you should contact the provider to ensure that you are safely giving that med or should give that med that day or hold it. So making sure that you have a staff member that is well trained and able to do that for you is key in this process. So we are building, as we're given this DOT, we're building trust and consistency, making sure that we're addressing any side effects that are subjective. So we're seeing and objective. So we're seeing and we're hearing what is happening. So perhaps the patient is denying side effects, but we're seeing them and we see a change. That is a visual note to address that and ask some questions before you give the medications to ensure you should give the medications that day. So you're also making sure that the supply chain is of medications is adequate. So ordering them ahead of time, making sure that there are no missed doses due to issues with the medications. Clinical monitoring, we're looking for those side effects. This is not a full list of side effects, but this is just a sample, if you will, of some of the things that we're going to be monitoring for and some of the more common issues with the 4 first-line medications that ocular TB patients get, which is isoniazid, pyrazidamide, rifampin, and ethambutol. We are going to be looking for reports of dark urine or GI upset, neuropathy. We're going to look for vision changes as we use those tools. And then we're going to be communicating with the provider, right? We're going to be doing all of those things. But these are all things that not only have to be performed, but they also have to be documented. Any assessments would be done by a registered nurse or above. 3 of the nursing books that I highly recommend that you have on your desk at all times, available either hard copy or electronic. They're available, and you can get those through the QR codes that are at the bottom, or you can go to the COE Center website and download these. I love these books because they are fabulous resources that help case management for nurses so much easier in the field. It provides tools regarding side effects, monitoring advice, as well as drug level testing and common comorbidities and considerations when faced with those comorbidities. So fabulous resources, highly recommend them. Please, please. And the Nursing Guide for Managing Side Effects does have the mini mental evaluation that I was talking about earlier. So highly recommend, if you haven't checked those out, that you do so. So now let's take what we've learned so far and see how it plays out in the case. You receive a referral from an ophthalmologist and you start gathering information. The ophthalmologist provides the following report, and surprisingly, sputum was indeed collected, yay, to assess for infectiousness. All results have been negative to date. So the results are from your gathering. You found out the person was initially referred because they had a positive IGRA and ocular inflammation, or uveitis, which triggered the ophthalmologist to tell you. You conduct immediate chart review, medical and ophthalmologist notes, and identify a need for TB rule-out. Requesting TB rule-out hasn't been completed yet, and then if it hasn't, you're going to facilitate that and then communicate to all partners. So you're going to try to find out how the ophthalmologist wants to handle it, who they would like you to collaborate with, if it's a ID specialist or if they'd like to work through your SMEs. You're going to want to have that discussion with the ophthalmologist. You're going to want to gather all the testing that is ruling out TB, pulmonary TB, if they've done it, like they have, chest imaging, baseline labs, HIV testing. Even if they're asymptomatic, you want that sputum result if they're questioning ocular TB disease or any other extrapulmonary. You're going to communicate to internal partners in your health department, whoever your process says to report to, your supervisor or someone else. You're going to contact the patient for introduction, setting up the intake assessment, explain the public health's role in the process, and this is all within the first 24 hours of the report. You're going to document. It's key to safe patient care. It provides legal protection, and effectively, it's an effective public health action to do. Ocular TB often requires multi-specialty coordination, as we talked about earlier. So that is a little bit more challenging than the typical TB case management process. Documentation provides a single reliable source of truth, so each provider understands the patient's status, exam findings, treatment plan, and also allows us as public health nurses to track visual changes, inflammation patterns, or treatment response. So it really does provide us with the ability to monitor more easily and efficiently. It will help us identify early signs of drug toxicity or drug adherence barriers. So very, very important part of the process. So now the public health nurse case manager does their intake evaluation and assessment and provides the following to their patient. Given the education, right? We are giving education and explaining ocular TB and why it's suspected, the diagnostic process for ocular TB and how it differs from other types of TB. We don't have the test, unfortunately, to be able to say for sure. What we do know is that you have this risk. You have a positive IGRA. You have risk for progression. You have this process going on that the ophthalmologist has attempted to treat unsuccessfully for however long. This is our next step. And trying to clarify our role in the process compared to the providers, that we provide coordination, safety monitoring, treatment support, education, and really try to help them through the process and ensure that they get through the process by addressing any concerns that they note. overview the importance of ruling out pulmonary TB without any respiratory symptoms. That might be questions that they may bring forward. Reinforcing that ocular TB is not usually contagious. Reducing the stigma and fear that we had talked about earlier. Using collected subjective and objective data and creating that nursing care plan is what I would say would help us as nurses to improve our process. In this particular case, right, we want to make sure that we are speaking in our patient's first language or our client's first language, so that you want to confirm that they do speak English fluently and there's no need for an interpreter. If there's a family member there that says that they don't want an interpreter, you should really get an interpreter to have that conversation, to have that refusal, because it didn't come from the person. So that's an aspect that I think we all struggle with because of the barriers to getting interpreters. But it is so very important, especially with ocular TB, because there's so many nuances and there's such a risk to the patient's vision that I think it's imperative that we do it for ocular TB. We want to look for those other potential vision issues that we have noted in our initial report from the patient. We're not doing a visual evaluation other than the Snellen and the Ishihara, but we do want to report anything to the ophthalmologist that the patient is telling us regarding their vision, especially if it does conflict with what they have written in their notes, because it might be new information to the provider as well. We need to make sure that they have an established PCP or ophthalmologist if this referral came from a private, their personal care provider versus an ophthalmologist. So you might need to get them established with an ophthalmologist, or you might need to get them established with a medical home. It's not uncommon to have to do that. And again, it would be pertinent for us to help with that process. So we also want to collect their medical history in their viewpoint, because again, we might not have medical records that they have because we don't know of a facility that they were seen at. We're relying on the information we know is out there. So knowing a person has diabetes and their A1C, their last A1C was 11 point something, is going to be pertinent if we can't find that in a record. So these are all things that you're going to be looking for. You're going to be looking for if their social history, were they ever exposed to TB? Perhaps this is a new infection and someone recently infected this person, and that is how they ended up with ocular TB. So finding out their psychosocial history and their family history might provide you with more evidence of who infected them. You might find the source case out of this as well. So medical insurance, you want to make sure that you cover that, because if they don't have medical insurance, you may have to help them get established with care if you're not a state that provides assistance with that. This person lives alone. Specific to this case, this person lives alone. She has no insurance. She's on a list of medications. Her last A1C was 7.2. She's an active smoker, no alcohol, born and raised in Mexico. That was her risk. No known exposure to anybody with active TB. Never experienced homelessness or incarceration. She uses the bus system. She's unemployed, hasn't been able to work in the last month due to her vision loss. And her family support, her self-report was feeling scared and alone, no family support system, not really having any friends that she stayed in contact with. nobody with similar experiences to really talk to about this. So we did talk about the TB survivor network and how that may be an option for her. Assessment for the individual's comprehension was taking place, and acceptance of the diagnosis process. Much education was provided because, again, there was a lot of confusion about that. The PHM response, we want to look at what we would do, right? Like, what is our response to knowing these additional psychosocial issues? So we know that there's a potential risk of depression. So we discussed the option of connecting her with those who have other experiences to provide emotional support, shared experiences, and practical knowledge of their experience. She had no HIV test done. We knew that through the medical records. So we did a rapid test at home, and it was HIV negative. We provided enablers to assist in travel needs because she said she uses bus pass, right? And then we worked with the individual regarding the medication administration on what times of the day would work for the LPHA staff and the patient staff to balance the burden on DOT in the home. And then identifying any potential risk for barriers to adherence, things like that. Those are the things that we're doing. We're providing our contact information and instructions to contact the public health nurse if there's any side effect or concerns or questions between now and the next time we meet. We want to make sure that they feel safe and open to contacting you. So in looking at your nursing diagnosis, we want to look at what you've collected so far. We have a risk for ineffective therapeutic regimen management related to unemployment, lack of insurance, limited social support, diabetes, vision impairment, and daily routine disruption. We have a risk for anxiety and fear related to potential vision loss, isolation, uncertainty about diagnosis and treatment. So what do we do with that? So I have more of those examples that I can provide later. But what do you do with that? You got for vision impairment and suspected ocular TB, problem 1. What is our goal? Our goal is to ensure timely diagnosis and clinical monitoring. Our intervention may be to coordinate through ophthalmology and educate the patient on red flags. Outcomes that we would like to see are improved clarity and on the diagnosis process and reduce risk of delay of starting treatment. Problem 2, maybe you say psychosocial. There's with the anxiety and fear and potentially even depression, there's a psychosocial vulnerability. So problem 2, goal would be to reduce the isolation fear. Interventions may be to peer support linkage to groups such as the TB Survivors Network, or routine check-ins and having those conversations and building that rapport and providing that safe space for them to have conversations. So these are just a few examples of how you could take this and incorporate it into a specific patient. So for short-term goals, you may want to, because again, the nursing process is all about making clear, measurable goals that are achievable in a time frame. So your short-term goal might be to have the patient verbalize understanding and acceptance of diagnosis, how the public health plays their role, or what the LPH and PHN public health nurse's role is specifically, and early warning signs for when to contact you. You might have a goal of patient demonstrates ability to communicate side effects promptly and use the agreed upon method to notify you. Those are some potential goals that you would have for short term. I'll give you an example of a 1 to 2 month. Patient adheres to treatment plan with over 90% adherence, or no severe medication side effects reported. Long-term plan might be treatment completed as prescribed. So these are some examples of the nursing process in action with the specific patient we were talking about. So the nursing diagnosis again, risk of vision loss, anxiety and fear, risk of depression, ineffective therapeutic regimen management, knowledge deficit, and adverse drug reactions. So these are things that I put together. You may come up with more because again, the nursing process is specific to your assessment, but these are things that I think tie into the patient education, psychosocial support, and providing that patient-centered, individualized care plan, and how we can do that and make sure that the patients really do stay on track and complete treatment without many issues, if at all. So when we look at the medication adherence support or other individualized nursing interventions that are on there, we want to look at, again, identifying those or breaking those down a little bit more for you as well. So in the medication and adherence support, you'd want to collaborate with the patient to choose the dosing times of day that don't create more burden for them, but also work with the local public health department. Should not be a burden for either one of you. You might provide side effect education, prioritizing the baseline health or comorbidities, co-management aspects. So perhaps providing some diabetic education, making sure that they understand their treatment for diabetes, and if they have any questions that need to be answered or addressed, or communication to their provider regarding these issues and topics that need more addressing. So these are things that we would want to keep in consideration. We don't want to negate any other comorbidity that plays a part in their life. This is a holistic view of the patient. Providing the established care plan and agreed upon care plan. It really should be a collaborative process with the patient. It's going to be something I believe will increase our professional standing with the patient, as well as our rapport and respect and ability to get real good clinical evidence for the providers that need it. For example, I want to give you something on the diabetes. So for example, more specific, monitoring for drug disease interactions, especially hepatotoxicity or hyperglycemia, that may be part of this. Reinforce importance of maintaining their glycemic control to support immune function and healing, and notifying PCP of treatment initiation and monitoring schedule. So those are some examples for specific diabetes and comorbidities. And these are all things that that are absolutely possible, not only possible, but really do play a part in the outcome of the patient. So when we're doing evaluations, we also, again, we're doing the treatment adherence oversight, and we are doing psychosocial support and patient education. So we are making sure that the patient in our evaluation process, like how are we going to be successful? We want to make sure the patient's attending appointments. We want to make sure that the transportation enablers that we're giving them are sufficient in getting them what they need to make those appointments. We want to make sure that we're using our proper way of communication and that the patient is comprehending the information in an adequate way. And the plan for side effects reporting is key. So that the patient communicating to the public health nurse that they understand what they will do if they have a side effect and when they will call is really pertinent. There should be no question in their mind what they need to do if they have to contact you. So we want to look for stability or improvement in the visual process as reported, self-reported. We want to make sure that those vision screening tools don't show any regress in their testing results, and if they do, you would refer to the ophthalmologist, right? We're going to make sure that we use safe laboratory parameters when doing testing, ensure that the patient's involved in care. We're going to make sure that the patient demonstrates accurate understanding through teachback of all of these processes to ensure that everybody's on the same page. And again, you are going to be documenting and communicating with the providers. So in our summary, in our patient that we had just gone through, what we did, right? We did the rapid HIV test in the home, provided enablers for transportation. We addressed the emotional distress by offering peer support. We developed a flexible medication administration plan to avoid any burden on the health department or the patient. We established communication protocols for reporting symptoms. We provided my contact card and clear instructions of when to call me. And we reinforced that it is non-infectious TB at this point, and to address the fear and isolation that they may be feeling right now. So we are addressing the needs as they come. So we're cruising along now with no observations or any reports of side effects or concerns at this point. We get to about 4 weeks into treatment, doing our care plan, everything's going great, but the patient reports significant nausea, stomach discomfort, vomiting since the last dose yesterday. They didn't call you yesterday to let you know, but they are letting you know now when you show up. They still feel a little nauseous. What do you do? What do we always do when someone reports something like that? We want to hold, right? We want to practice caution. We want to contact the prescribing provider to report what the patient is saying and our clinical findings after our assessment of the issue or the reported side effect. And then we're going to get that information on what the provider wants to do. They likely will get a liver toxicity check because these would be something that you could see in liver toxicity. So you do want to find out if they want a CMP or a liver panel, find out if they want any other testing in the process and what they want you to do, and then document that in the patient record as well. You also want to find out from the patient, did anything change? Because this was 4 weeks into treatment, right? And they were doing fine up until yesterday. Could this be a stomach bug? Yes, it could. Could this be something related to another medication that they just started and they didn't tell you? So you want to find out, has anything changed in your diet, in your medications, in your sleep or habits? And find out what those could be to evaluate if that could be driving us towards side effects when it's actually something else. So all of these things are very, very important, not for you to know, but for the provider to know as well, because we don't want to falsely associate a side effect to something that is so important in our regimen that has significant purpose in our regimen, especially with ocular TB, because it is such a nuanced place in the body where it's not the same as in any other extrapulmonary disease process. It's a little tougher for the medications to get through the barrier of the eye. So when the liver function test came back, right, we found out they're all within normal limits. The provider orders the medications to be reintroduced one at a time to see which drug is causing the complaint, which was done. The patient reports no symptoms after rifampin and INH were reintroduced, but nausea when the EMB was reintroduced. They remained on all 3 of those, and they introduced the PZA, and patient again had nausea. So the TB medical doctor who was reconsulted and recommended dropping PZA now and completing initial phase for another 4 weeks with RIE, reassess for ocular improvement, and if improved, determined to be a clinical case of ocular TB, and then transition to RI, rifampin and INH, to complete 6 months of treatment. Documentation of the plan was made and is now being followed. So the care plan moving forward, pretty much the same. We're just going to be monitoring closely, right? We're just going to be medication adherence. We're going to make sure that they're receiving the prescribed medication, that they're getting them through DOT or VDOT, which is a video recorded electronic option for DOT. Communication for the side effects and reporting, reinforce teachbacks to make sure that you're recognizing any flags in the communication process and addressing them. Monitoring for safety, you're looking for that psychosocial and emotional support. So with the monitoring and safety, making sure your assessments are being done in a timely manner, make sure follow-up appointments are being made, making sure that you're monitoring for any toxicity or for ocular changes. The psychosocial, we're going into peer support engagement, perhaps if the patient's willing to do that for the emotional coping and depression risk. Monitoring for any worsening signs of depression or anxiety and addressing those with the provider as they come. Access and logistics, we're making sure they have those bus passes. We're making sure they have any support to making those appointments and helping streamline that process. It's a very challenging process for people to work on through our healthcare system, even if they have English as a first language and they know the system, it's challenging. So any barrier to that is something I think we need to help with. Evaluation and anticipated outcomes, we're going to want to make sure that they take more than 90% of the meds, that they stay stable and they have improving vision, minimal to no side effects from meds, complete therapy without interruption if possible, reinforcing knowledge, coping strategies, and self-efficacy, notifying provider when they're nearing the 8 weeks so that we can arrange for that follow-up evaluation and time to determine if it's going to be a clinical case or not, and continuing monitoring until the process is complete or treatment has completed. So this is a sample tool that we provided in your packet of information for this webinar. In preparing for this webinar and with the rising cases of ocular TB in our state, I really am coming to the conclusion that a lot of public health nurses are very, very uncomfortable with ocular TB because it hasn't been prevalent in the United States. We've seen a few cases, but I think we're not quite as comfortable as we should be with this process of case management specific to ocular TB. So what I'm proposing is for a more streamlined screening tool for specific disease processes to improve focused care in the field. This would help ensure comprehensive evaluations for complex conditions such as ocular TB, improving early detection, standardizing care quality across the country, empowering patient self-management, and facilitating tailored interventions. Our goal is to really lead a patient to a better outcome, and efficient resources for the public health nurses are not only needed, we are begging for them. We need to have more specific tools that are targeted to the specific disease processes that have that include potential co-adjunct medications such as steroid use, and how we need to monitor for that. This will only help us and the patient and the provider. There's no real downfall to having something like this that is going to help the nurses. So I want to be clear, this is not an approved tool. This is a sample or an example of something that we could consider creating through a national organization or through our states. But I think it would help streamline the process and ensure better patient outcomes. So guess what? Now that you've followed all the steps, you've successfully guided your patient through completion of TB treatment. Congratulations. I really, really appreciate your attention today. I appreciate your patience with us, and I am pleased to introduce our next speaker. She is a proud TB survivor, and more importantly, she's a mom to a lively 2-year-old newborn baby daughter, celebrating 10 years of service with HUD in Detroit, and spends her free time turning wooden bowls with her husband and creating embroidery pieces. Her story is one of resilience, joy, and creativity. Christy, take it away.
Hi, everybody. Thank you for having me. I will keep my story sort of short and sweet here because I know we're running a little bit tight on time. So I was a Peace Corps volunteer from 2012 to 2014. I lived in this tiny little African country called Malawi, where I worked in a health clinic there, and I worked really closely with the population. It was like 50,000 people to one doctor, just insane numbers. And so I was in and out of the health clinic almost daily. I lived on site at the hospital, and in my exit health exam with the Peace Corps, I tested positive for TB with a skin test. At that time, I had no other symptoms. I was not given a chest x-ray. I was basically told, you're young and you're healthy and, you know, you've been exposed to TB, you're going to be fine. Go back to the United States. Don't worry about it. You'll probably never come up again. Good luck, basically. And so I went about my life and I moved back to the United States in 2014. And in 2016, I woke up one day with just extreme pain in my eye. And so I went to like a little ophthalmologist. I lived in downtown Detroit at the time. And he said, oh yeah, you know, it's uveitis. A lot of things can cause uveitis. It could be lupus, it could be cancer, you know, it could be tuberculosis. It's probably nothing. Like, you're pretty young, you're pretty healthy. Don't worry about it. And I was like, that sounds like something I've heard before. Do you think I should get a referral? You know, here I'm Googling in the waiting room, you know, U of M has a uveitis clinic. He's like, you're never going to get into U of M. This is your first uveitis flare up. Usually if you have uveitis multiple times, you can get into U of M, but they're not going to take you. You're never going to be able to get in there. Here's some eye drops. You're going to be fine. Just go home. And so I called U of M, and I explained to them, you know, I was in the Peace Corps. I've been back, you know, in the United States for, you know, less than 2 years. And I did have a positive TB test, and I did just get a positive uveitis test. Can I get into the uveitis clinic? They said, let me consult with the doctor and see what she says. And she called me back almost immediately and said, yeah, we can get you in tomorrow. So I went to U of M. I got into the clinic. They said, yeah, we're going to run all these different tests and see, you know, by process of elimination, is this TB uveitis? And all the tests that they ran, I mean, it was vials and vials of blood. They came back and said, yeah, the only thing that's coming up positive here is the TB. So we're going to transfer you over to infectious disease at U of M. So, you know, waited a couple weeks to get an appointment there, got in there, and they said, oh yeah, we've really never dealt with this before, but we know a guy that's really good. And he's actually on the call, Dr. Sundstrom. And they said, you should, you know, get into his office. He'll know what to do. And I'm like, okay. So, you know, it's been a couple weeks at this point. I call his office and they're like, he's in Africa. He's going to be gone for, you know, a month. So I finally get in to see him. At this point, between, you know, being diagnosed and getting actually on a treatment plan, it's been like almost 2 months of, you know, a period of time here. And so he started me on a treatment plan. Very great. I was feeling really crappy. I didn't like being on treatment. And then, you know, probably, I don't know, maybe a few weeks into my treatment with him, he says, you know, I really should be transferring you to the Wayne County CDC. And so that point, then I transferred my care from him to the Wayne County CDC because that's, you know, the right protocol there. And then I probably was the worst patient the Wayne County CDC's ever had. I was like, didn't want to do DOT. I wasn't doing DOT. I was adamant that, I was going to take my medicine, but they were like, no, you're doing DOT. And, had continued my treatment on there, for another, it must have been like 7 months at that point. I was on a 9-month treatment plan. And so it was a very challenging treatment for me, because almost immediately after I had seen U of M, I was put on a steroid drop and I was feeling better. I was still having uveitis pain, but it wasn't nearly as severe. And so taking the medication, to me, I was having really bad side effects. I was having really bad migraines. I didn't want to take the medication. It was probably a good thing they put me on DOT. And I learned a lot about TB at that point. And had I known that I could have gotten, a treatment for having TB when I was in Africa, that could have been, a couple months. I would have preferred that route than having to be on this medication for 9 months. But it was really challenging. It was challenging to navigate. I was very lucky and very thankful that I was working with people that, actually cared, but I had to really advocate for myself. And I think that that's really challenging. It's really challenging, as an affluent white American woman to do that. I can't imagine what it's like for someone that is, not speaking English, or someone who doesn't have, the resources to advocate for themselves. I mean, I think about my life now with 2 small children. I wouldn't be, able to spend all day on the phone and making appointments and waiting for doctors and everything else. So I think it's really important that, we are diagnosing people and getting, to the bottom of these things quicker. But that's my story. Since then, I have worked with We Are TB, and they are an organization that is advocating on behalf of TB survivors, but they're also meeting every week to kind of have some patient connection and help people feel a little less isolated. And so I was going to share my screen just for a quick second, just to show you the We Are TB website. I'm not going to spend too much time on that. I just want you guys to have that as a resource for your patients. And we also meet in Spanish, Somos TB. They meet in Spanish once a month, and they meet every Monday in English. So if you have patients that want to be able to meet and talk, that are feeling, isolated, that want to have conversations with other people that have had similar experiences, it's definitely a good resource. And there's also some resources on the website for just different patient pamphlets and things that you guys can utilize at your health clinics. And so if you have patients that are interested, they can click on that patient support tab up there at the top. And there's a little form, and you can fill out that you're interested in being joining our Zoom information. Kate O'Brien does a really good job, making sure that it's a safe space for everyone. And she sort of does a little bit of vetting before people get on the call. So it's not just like, anybody random on there. And she's built, along with the people that are involved with We Are TB, a really good community, a really active community of people that are very supportive and that are doing outreach and helping support other patients. So if you have anybody that, just wants to talk, we have a lot of people from a lot of different backgrounds. So if, not just in Spanish, we have people that are speaking Arabic, we have people that are speaking other languages. So just keep this in your back pocket as well. We'd love to have anybody with us. And at that, I'm going to wrap up and say, that's my story.
Awesome.
Happy to take questions.
We'll collect questions because of the time and have you answer them and get those out to everyone. But I do have one question for you. If you have one piece of advice for a provider back when you learned that you had TB infection, or could go back in time to express to the provider, what would you say to the provider about the preventative therapy? How would you best put your feelings about that?
I feel like the The direct observed therapy was really challenging. I understand the need for making sure that, these drugs are being taken, but at the same time, I feel like when you are being pushed around sort of by all of these different providers and you're getting kind of met with roadblocks after roadblocks, it's really hard to feel like heard or seen when you get to that point. Because I feel like at that point, my patience was already gone. I was already feeling like I wasn't, um, you know, being heard and I wasn't being taken seriously and that people really weren't trying to treat me. And I know that people were just trying to get me into the right place. But from my perspective, that's not how it felt.
Yeah. How do you feel about the case management stuff that I was going through, like trying to refocus on more of a patient collaborative process in the care plan and really focusing on improving the collaboration and the communication so that the patients don't feel like they're being bombarded by all these different entities and you have one person that's being able to communicate?
I think things are a lot different now because, we have this technology where we can do things a little bit differently. I think since COVID, we have become more of a digital world and we are more comfortable doing things like via Zoom or, over the phone, where that was kind of a new thing when I was on my TB treatment. It was almost 10 years ago now at this point. And so,
Sure.
I think having that sort of as an option is a game changer. I was able to have like a few of my treatments done like that, but they certainly all weren't done like that. And so, having to go into the clinic and having to, go and, take time out of my day. I think about that now, like with two small kids. It's like if I had to go into a doctor's office every day or several times a week to get medication, that's not going to happen. I'm just bringing two small kids everywhere I go. Like, I'm thankful that I have a very competent and capable husband who can, watch our children, but not everyone has that. And we also have very flexible jobs. And so, it's really challenging. You have to fit that in between commuting and working and grocery shopping and feeding children and daycare and everything else. It's just not going to happen.
Yes. Boy, Christy, I would really love to work with you more if you're willing to work with me a little bit more, because I'd like to improve, especially the ocular tuberculosis case management for us nurses to improve our care and how we deliver it. So if you're up for that, that'd be great. I would like to turn this back over to Curry to close this session out if possible.
I'll hop in. You guys have been wonderful. It's Lisa Chen from the Curry. I've been sitting in the background. I really do appreciate it. Thank you all for staying. Thanks to the National TB Nurses Coalition for, partnering on this, because this was a wonderful collective event. And Christy, oh my God, such a good reminder story for all of us to be better. So take care.